Welcome back for the second session of the day. I will have the honor to co-chair this session with my friend Dr. Hadi من القاهرة من عين شمس. Dr. Hadi needs not a lot of introduction. Actually, he is one of the gurus of interventional cardiology in Egypt, as well as in the area and internationally. Welcome to Amman, Adil. We will be joined by colleague panelist Dr. Mohammed Motter من العراق. أهلا وسهلا فيه. دكتور وليد صوالحة. وليد موجود. Dr. Rashid Ibtah, I could see you. Dr. Amr Kermi, I could not see him. We'll manage anyways. We had a change of schedule. Hopefully Antonio Colombo will join us as the last presenter and speaker. And we will start with the first presentation. We are focusing on drug coating balloon, where we are and how to use it in PCI in 2024. عادل.
أولا طبعا أحب أشكر الدكتور محمود على دعوتي للمؤتمر المتميز وطبعا في الأردن الشقيقة وفي وجود أستاذنا الأستاذ العظيم دكتور يوسف خصوص، وهو الحقيقة يعني بالعلاقة بين الأردن ومصر في الكارديولوجي قامت على عظماء زي الدكتور يوسف والدكتور علي رمزي ومجموعة من أطباء القلب في مصر وفي الأردن. الحقيقة طبعا بيشرفني وجودي مع أخويا الدكتور هادي أبو حنطش. أنا أحب أعرف نفسي، أنا الدكتور عدي أتربي أستاذ أمراض القلب في طب عين شمس والرئيس السابق للجمعية المصرية لأمراض القلب. الحقيقة ال DCB has been gaining too much attention during the last couple of years. We all know the top indications, which is in-stent restenosis and small vessel disease, but now the horizon is expanding, and we will see in these two lectures that the horizon is expanding to bifurcations, osteal lesions, CTOs. So DCB is going to conquer the world again, and I think it's not a replacement for stents, but it will be an addition to stenting, what they call now hybrid techniques, stenting and DCBs, and sometimes DCBs only in some situations like acute MI and thrombus-containing lesions. It's a pleasure for me to be chairing this session, and I would like to introduce the first speaker, Dr. Nizar Al-Shakshir from Palestine, and he will be presenting DCB, Is It Always the Answer?
مرحبا. احنا في جمعية القلب الفلسطينية كتير يشرفنا انه احنا نكون مدعوين للمشاركة في المينا PCI في عام الخامس. نشكر دكتور زريق وزملائنا المنظمين لهذا المؤتمر. هذه السنة سنة مميزة لنا بفلسطين بسبب الظروف والحرب اللي احنا بنعيشها. احنا هون اطباء القلب بنشارك في هذا المؤتمر، ونفس الوقت بنتذكر زملائنا في الكادر الطبي في غزة اللي بيقوموا في واجبهم في ظل الحرب الشنيعة اللي عم بتتم على شعبنا الفلسطيني في غزة. ونوجه تحيتنا من هون من الأردن لزملائنا في فلسطين في غزة وفي الضفة الغربية. رح نبدأ بالبرزنتيشن. زي ما حكى الدكتور، احنا drug coating balloon is becoming a more favorable thing لنا نستعمله سواء في bifurcation, small vessel disease وحتى في normal vessels. في عنا this is a 55-year-old man who's known to have hypertension, type 2 diabetes mellitus, and he's a smoker. He presented to us with typical effort angina. His ECG showed a sinus rhythm with a lateral ST depression. His echo showed a mild LV systolic impairment. His blood tests were unremarkable, and he had negative cardiac enzymes. This is his diagnostic cardiac cath. I'm sure you can all appreciate the proximal left circumflex disease, as well as the severe disease in the mid-distal LAD. His right coronary artery showed only mild plaque disease. Initially, we thought that he had the lateral ST changes on his ECG and we'd better fix the left circumflex. This was fairly uneventful. We've put a stent and a further stent to the left circumflex, which was fixed. Looking at the LAD, we thought, well, this is a young man, he might require a bypass surgery in the future. So we thought we're not going to use stents in the LAD, so we've done ballooning, and then we've used a drug-coated balloons. When we look at the final result here in the LAD, I'm sure that most of us would accept this as a decent result with a drug-coated balloon. This is the final results here as we could see it. Normally when we use drug-coated balloon, we don't expect the results to be as perfect as we see it with drug-eluting stents, but we look at the TIMI flow, we make sure that there is no dissection with the wire-out shots, and we thought this is a fairly reasonable result. This patient was discharged home in the morning, and he was doing well. Next day, he presented again with severe chest pain, shortness of breath. His troponin was raised at 22 in the peripheral hospital, and our normal result is less than 0.02. So this was a major raise in troponin, having that he hadn't had a myocardial infarction. He was admitted to the peripheral hospital. He was transferred to us again for further coronary angiography. We've had another look at the RCA, which again was unchanged from previously. Looking at the stents in the left circumflex, they were fairly patent with a good runoff. The initial look at the LAD was fine, but then when we looked at it in the areocranial, which is this view, I'm sure you could all appreciate this dissection here in the mid-LAD, and it looked fairly hazy. So we thought that his second presentation was mainly due to this dissection, and he might have had a temporary blockage in the LAD, which caused his fairly high troponin. This was fairly unusual for us. We don't normally see these things with drug-coated balloon results, but we thought we couldn't leave this with just ballooning, so we had to use a drug-eluting stent. I thought we used a 275 by 18. And again, the second lesion didn't look that nice, so we've covered it with the same stent, and this was our final result. Thank you.
Thank you so much, Nizar. He over-restricted his time.
Yeah.
This is really wonderful. Thank you very much. We'll keep the discussion towards the end. Let me introduce my colleague, Dr. Mustafa Al-Jamal. Mustafa will present a case of osteoarthritis severe lesion. Stent or DCB is the question.
Thank you. Good morning, everybody. I'd like to present this case, to share this case with you. It's about a 55-year-old male patient, diabetic for 15 years, hypertensive for 15 years too, with status of the part myocardial infarction, and where he received his first stent. It was followed by multiple acute coronary syndromes and stents and instant restenosis and DCB PTCA. PTCAs, the last one was for LAD instant restenosis on the 16th of June 2023. On the the 21st of October 2023, he was admitted through the ER with the chest pain and anterolateral 1 millimeter ST depression. And here is the angiogram. You see the LED stent, how beautifully looks the result after doing it previously with the DCB, where it was the classical best indication for DCB. As you see here, there's the ostial ramus, which was stented before paraostially, and here is the only culprit lesion is the ostial ramus. He was very symptomatic. I tried with him conservative medical treatment, and he was still symptomatic. So the CAT showed that this is the only culprit lesion that explains his complaints. The RCA has nothing. So I prepared the vessel with the PUBA, and the result was fairly good. There was no flow limiting dissection or type C dissection. So I decided to go for DCB. And here was the final result. On the 17th of December, he was admitted with chest pain, and of course, because he has telltale story of multiple PCIs and atherosclerotic cardiovascular disease and recent PTCA, I decided to cath him to see what happened with that lesion. And this is the follow-up of this de novo lesion that was managed with the DCB. Thank you. As you know, when it's a branch of the left main, when you want to tackle the ostial lesion at this site, it may turn into or it may transform into more complex procedure that implies using heavy load of metal and risk of left main thrombosis, because you'll be obliged to deploy your stent cover from the left main to that vessel. And if you can solve it with this method, you get rid out of a more complex procedure. In fact, angioplasty was not given the credit from the beginning of interventional cardiology. Interventional cardiology started with PTCA, and there was acute complication in form of abrupt vessel occlusion and late restenosis of the vessel after PTCA. Then the stent was invented to rescue these dissections that result in acute myocardial infarction, and there's nothing to do at that time. There was people encountered high incidence of acute thrombosis. It exceeded 20% in some papers, until they discovered the ADB inhibitors. But at the time of angioplasty with PUBA, there was no dual antiplatelet therapy. And there was no drug eluting. Drug eluting was invented to prevent the late instant restenosis after using the bare metal stent. So the stents progressed to advance and to achieve lower target vessel revascularization.
Can you hear us very clear?
But
I hear not so clear, but
let's see what happens with
Okay.
angioplasty.
I will answer to adjust the truth.
We don't encounter type C lesion or flow limiting lesion. In the era of dual antiplatelet therapy, most of the limited trials done on DCBs, they found that the risk of
better now.
reaches sometimes zero.
yeah, I hear.
And
It's okay.
to deal with the late
Okay,
restenosis
okay.
after angioplasty, they eluted the balloons and they could prevent late restenosis by applying a toxic cytotoxic drug to the intima. And the idea is simple. Whenever you prepare your vessel and there is no type C dissection or flow limiting lesion, you can apply a drug coated balloon and you can achieve target revascularization comparable with the drug eluting stents. Thank you.
Thank you. I think if Antonio is ready, we will shift to Dr. Antonio. If not, we will start discussions for the two lectures. He's ready?
Yes. Allow me to introduce. I call him the pioneer of modern interventional cardiology, at least in my opinion. Antonio Colombo is really does not need any introduction. Antonio, this is Hadi from Amman. Can you hear us?
Yes, I can hear you, I can see you.
Oh,
I'm
that's
going to
good.
share my screen.
Okay, we can see your screen here. I'm joined, co-chairing the session with Dr. Adil Atribi from Cairo 2.
Okay, you let me know if you see my first slide with the title.
We are seeing it very clearly, Antonio.
Okay, I'm ready anytime.
Well, we're ready for you. I just to cut it short, I cannot speak a lot about your background and who you are. Everybody knows Antonio Colombo in the audience, so just feel free and start, Antonio.
Okay, first of all, thank you for this opportunity. I'm sorry I cannot be with you in Amman, but I try. Yes, I can hear you, I can see you. I'm going to share my screen.
We can see your screen here. I'm joined, co-chairing the session with Dr. Adil Atribi from Cairo 2.
Okay, you let me know if you see my first slide with the title.
We're seeing it very clearly, Antonio.
Okay, I'm ready anytime.
Well, we're ready for you. Just to cut it short, I cannot speak a lot about your background and who you are. Everybody knows Antonio Colombo in the audience, so just feel free and start.
Okay, first of all, thank you for this opportunity. I'm sorry I cannot be with you in Amman, but I try to give the message in an educational fashion anyway. So the title of my presentation is Optimal Stent in Complex Lesion and Use of DCB. I will spend more time regarding use of DCB because I believe optimal stent is kind of common knowledge already. I have no conflict to disclose them. So the concept of optimal stenting, in my opinion, starts in 1995 when we wrote about the value of IBUS. It really took more than 30 years to incorporate IBUS optimization in coronary stenting. Of course, the difference is not dramatic but there is an advantage if you do IVUS, especially in complex lesion. At that time, the work was mainly for stent thrombosis. We did not do a randomized study, but we evaluated 359 patients with aspirin, teclopidine, and IVUS evaluation. And despite the usage of a thick strut palmar shot stent, the thrombosis rate was less than 1%. And this is, it's really remarkable 30 years ago. IVUS originally was introduced to lower stent thrombosis, but as I said now, is becoming important to lower restenosis, less reintervention, and in some subsets, like in the left main, to lower death. So it's very important to know that IVUS does not work by the intention to treat. Why do I say that? Because the fact that you do IVUS does not mean that the IVUS had an impact unless you react to the IVUS and you obtain what is supposed to be obtained, which is stent optimization. Because if you just do IVUS and you don't achieve a proper stent expansion, that has no meaning. How do you achieve optimal stent expansion? Now we have many devices. The old rotablator is still very important. We have lithotripsy, we have very high pressure balloon, we have cutting balloon for classic lesions, etc. But the goal is to achieve stent optimization. And finally, there are several papers that confirm that intravascular imaging has an impact. This is the recent meta-analysis by Greg Stone published in Lancet and compare with angiography intravascular guidance of coronary stent implantation with OCT or IVUS enhance both the safety and effectiveness of PCI, reducing the risk of death, myocardial infarction, repeat revascularization, and stent thrombosis. This is a small meta-analysis which basically confirm the above findings published in Circulation. IVUS-guided PCI was associated with a reduction of ischemia-driven target lesion revascularization. In contrast, there were no difference in myocardial infarction between the two strategies. So some studies have an impact in MI and death, some other studies only in revascularization. I want to just to digress a second and spend 2 or 3 slides regarding bifurcation PCI, because this is a very important field and always open to discussion and progress. So how do I perform in 2024 PCI in complex bifurcation, which is Medina 111? I predilate both branches. If the side branch is diseased and is important, 2.5 or bigger, and is stenosed, I predilate both branches. I do kissing balloon before stenting, and then I evaluate the result, consider cutting balloon if the side branch result is suboptimal. At this point, after lesion preparation, I decide which strategy to use. I use DS, drug-eluting stent in the main branch, unless the result is perfect. If the result is perfect, I may consider drug-coated balloon. I perform a kissing balloon after DS on the main branch, And if the side branch lumen is adequate, I perform DCB, drug-coated balloon on the side branch and balloon on the main branch. If the side branch lumen is inadequate or occlusive dissection on the side branch, I perform drug-eluting stent on the side branch with the T technique. This is one slide, and in my opinion, this covers 90% of the bifurcation. This is one example. You see a bifurcation, there is some left main disease, but please concentrate on the LAD and diagonal. Big diagonal, Medina 111. We predilate both branches. We perform a kissing balloon, and then we make the decision. Here, the plan was to stent the main branch and to do provisional with drug-coated balloon on the side branch. But you see, the result on the main branch is so perfect. There is a dissection on the side branch, but in the main branch is so perfect. And we even measure pressure gradient, and PDPA on the main branch was 1, on the side branch 0.9, 0.91, 0.09. So we perform a drug-coated balloon on both branches, and we didn't even implant a stent. This is a little bit extreme, but nothing wrong to place a stent on the LAD, but the side branch is well treated with a kissing balloon. But now let's change the area and go directly in the drug-coated balloon field. Last year with Pier Pasquale Leone, I wrote this point of view in the European Heart Journal with the title Redefining the Way to Perform PCI, a view in search of evidence. And evidence is built. But the main point of this point of view was that optimal stent implantation, imaging guided, and resurgence of bioresorbable scaffold should be important tools in PCI. Routine stenting may be avoided when there is the possibility to deliver an anti-restenotic drug after having achieved a good dilatation result. Please, after having achieved a good dilatation result, otherwise you implant a stent. And the story of drug-coated balloon starts in 2006 with this seminal paper by Bruno Scheller, treatment of coronary ISR in stent restenosis with paclitaxel-coated balloon. Believe it or not, only 52 patients was sufficient to get the New England Journal of Medicine. Now there is a resurgence of drug-coated balloon, and we see paclitaxel, which is the traditional, and sirolimus. Sirolimus is considered more friendly, but we still do not have solid data to tell that sirolimus is as effective as paclitaxel. We are building data, but at the moment there is a lot of green because it's less cytotoxic, but the tissue absorption of sirolimus is slow, is not fast like paclitaxel, and the tissue retention is short and not long. There is a new ways to make sirolimus similar to paclitaxel regarding absorption and retention, and we hope this new approach will have an impact. We have to wait another year at least. But the message to me is drug-coated balloon are heterogeneous, even among paclitaxel and sirolimus. Each DCB needs to be evaluated individually, and we should not talk regarding DCB as a class. But let's go to some practical areas. When to use DCB? The number one indication is in-stent restenosis. But I underline, when pre-dilatation results are optimal, otherwise you have to implant another stent. In small vessel PCI, there is plenty of studies supporting this. But the new application to me are written in yellow. to simplify the procedure, to avoid full metal jacket, especially on the LAD, and in high bleeding risk patient, to avoid excessive stenting with the need of prolonged dual antiplatelet therapy. Here, some slides regarding ISR. I like the Desire 4 trial, which shows that binary stenosis and diameter stenosis at 6 months, if you use a drug-coated balloon and a scoring balloon, angiosculpt, most probably the same for cutting balloon, both wrist stenosis and diameter stenosis go down. So I think for ISR, we routinely use a cutting balloon or scoring balloon before DS. Regarding small vessels, we have the Bello study published a few years ago in JACC, and the 2 years follow-up, where there is an advantage of DCB compared to stenting in a vessel 2.5 or smaller. And this result has been confirmed by the basket small 2 published in Lancet. Again, many patients, more than 700 patients, DCB versus death in small vessel with low MACE 7.5, 7.3, 5 cardiac death, but not significantly different, and low stent thrombosis. What is interesting is sub-analysis of the Bello trial and of the basket point of a possible advantage of DCB versus stent in diabetics. In the basket, there were 242 diabetics, and with DCB, the MACE rate went from 15 to 9. This is a working hypothesis, but very interesting, and maybe we should use more DCB in diabetics. But let's go to some example, how to simplify the procedure. You see this diffuse disease circumflex. If you implant a stent, you will have carina shift towards the LAD. Maybe you have to dilate the LAD, sometimes implanted 2 stents. We did a simple 2.5 semi-compliant balloon on the circumflex, a drug-coated balloon. Here's the result after 1 year. Very simple procedure, even not expensive, no stent, and there is an advantage. This is another typical example, ostial circumflex. If you implant a stent is okay, but with the drug-coated balloon, we got a good result with cutting balloon, no carina sheet towards the LAD, and this is 1 year result, minimal late loss, and good patency. This is a trifurcation, LAD circumflex intermediate ramus, dilated with kissing balloon, drug-coated balloon, and here immediate result with very good lumen and no stent at all. Diffuse disease of the distal right, bifurcation with the PDA. Again, the procedure is simplified, long semi-compliant balloon 2.5, long DCB, kissing balloon at high pressure, kissing balloon with drug-coated balloon, no stent, and the procedure is quite simple. Left main bifurcation with a mammary on the LAD. What you see is a big diagonal, rotablation on both branches, reopening of the obtuse marginal branch, a drug-coated balloon on the left main, on the OM, no stent, very good result. At 7 months, there is a focal restenosis, but very short in the circumflex, and in the OM, the bifurcation is pristine, simple short stent in the circumflex, and another DCB on the OM. This is diffuse disease LAD, no full metal jacket, rotablation, too long DCB. This is the result after 6 months with a normal FFR, DFR 091, and no full metal jacket on the LAD. Sometimes we can use hybrid, diffuse disease LED, we do high pressure balloon, lithotripsy, we implant a short drug-eluting stent proximally and too long DCB distally, and here is a 1 year follow-up. These are not just case examples, there are several of these cases published in this paper by Mauro Gitto of our group last year, drug-coated balloon angioplasty for de novo lesion in diffuse disease of the LAD, and we compare 147 DCB-based PCI versus drug-eluting stent only PCI, and you see the TLR is in favor of DCB. The MACE and the TVR are not statistically significant, but I guess if we have more patients, even the other two variables will become significant. This is a typical example of diffuse disease LAD, FFR 72, treated with long predilatation. The FFR goes up to 87, and then we apply 3 long drug-coated balloons. Here the example. We use this strategy in 104 patients, and we had to use the stents in 20 of them. So in 83, we were able to do the procedure only with DCB, guided by PDPA. In 20, we implanted some long stents or focal stents. So 20% is the need of stenting if you use a DCB-based approach utilizing PDPA as a trigger to implant a stent or leave it alone. Here the 12-month result with 0 thrombosis, only 5 target lesion failure. In high bleeding risk is the last group. This is an 88-year-old gentleman with atrial fibrillation receiving NOAC. You don't want to give dual antiplatelet therapy for a long time. You see LAD as diffuse disease, right coronary artery, many lesions. This patient traditionally will be treated with 3 or 4 drug-eluting stents, and then you have to deal with atrial fibrillation, NOAC, and dual antiplatelet therapy. We did rotablation, 3 DCB, a cutting balloon with a good immediate result, not a single stent, and this is a 6 months follow-up with a good patency. Of course, we need more data. There is a big study going on, 3,326 patients utilizing the solution for de novo lesion, any size, 3.5 included, 4.0, and the target vessel failure at 30 days, at 6 months, at 5 years as the endpoint. So far, they enrolled more than 2,200 patients with a crossover to stent of 18%. So more or less what has been our experience of 20%, and more important, no safety concerns. So final slides, how to use DCB. Optimal lesion preparation, mainly with non-compliant balloon, sized according to angiography, not oversized with IVUS. Imaging IVUS to select specific device to treat calcium and to evaluate residual lumen after dilatation. Try to dissect the plaque and note the media of the adventitia. For this reason, high pressure, non-compliant balloon or cutting balloon should be undersized. When treating diffuse disease, angiographic sizing may not be reliable, and we use IVUS, but we undersize at least 1 millimeter from media to media. And as I said at the beginning, use a cutting a scoring balloon before DCB for in-stent restenosis. And DCB is mainly to deliver the medication. You have to obtain a good result before using DCB. This is an example of a dissection. You see a dissection of IVUS with a false lumen, but it's very small. The true lumen is very large. You don't need to implant a stent because the true lumen is large enough. A focal lesion in the right coronary artery, there is a dissection, but the lumen angiographically is very large, no need to implant a stent. As a matter of fact, we also did PDPA, which was 99 and 88 in the distal PDS. These are various examples. So to conclude, I like to redefine the way to perform a PCI. DCB are as deliverable as DS. DCB are as safe as DS. We have plenty of studies supporting this. DCB will close the left side branches compared to DS. DCB allow positive vessel remodeling. DCB preserve vasoreactivity, and DCB do not always need prolonged DAPT. Again, DCB are not against stenting. DCB are helping stenting in situations where stenting results are suboptimal. Thank you for your attention.
Can we see your face now rather than the slides? So we will open the floor for discussion. Great. But thank you for this comprehensive overview of blood coating balloons. Let me just make a comment here. Antonio, frankly, in Milan, do you use only Sirolimus DCB versus back-to-back?
No. We use paclitaxel DCB and sirolimus. We are doing studies comparing each one against the other, and I hope next year we will have some results because we need angiographic follow-up to establish if sirolimus is equivalent, better, or inferior compared to paclitaxel.
Wonderful. Dr. Hadi?
Yes, thank you very much, Dr. Antonio. I've been following you on your new endeavor of expanding the use of DCB. Back in the old days, having a dissection was part of the success of balloon dilatation. Can you clarify this one thing? Clarify which dissection you will leave and which you will put a stent. This is one thing. The second thing
the dissection is visible angiographically, of course, and the dye in the dissection has to clear immediately. No dye in the dissection. And second, the lumen, not of the dissection, but the lumen in the artery has to be large in both projections. So residual lumen with a stenosis less than 30%, very good residual lumen, and the dye in the dissection clears completely. Of course, Dimitri flow, there's no question. But residual lumen and dye clearance.
Second thing that I noticed in a live case of yours, that you're using physiological system post-dilatation, keeping the wire in the distality beside another wire. Is there a role for QFR, angiographic QFR, rather than wiring the IFR in the future for assessment?
Yeah. I think, very good question. I think QFR may be used. I do not have experience much, only some cases with QFR, but I think QFR may be a simple way to evaluate the result. And if you have experience with QFR and you do QFR and you demonstrate that the numbers are more than 0.9, maybe you don't need a pressure wire.
Any more questions? Our colleague Mendes, please go ahead.
So, good morning, sir. It's my great pleasure to meeting you, talking to you, and my dream become real. I have a couple of questions. I want to summarize my questions in three more practical ones. The first question is: there is any rule for the DCB in this ISR? The second question: in case of the recoil after DCB, shall we go to stent only recoil segment or all dilated segment after using DCB? And third question, what's the pattern of ISR after DCB? It's a benign or more malignant than this ISR. And thank you very much.
So the first question is, we treat with DCB all the segment that has been treated with a pre-dilatation. So we prefer to use long DCB to make sure to cover the whole area. So if we dilate it with a 20 millimeter balloon, in order to be safe, we use the 30 millimeter DCB, not to have any geographical miss. I didn't hear the second question about ISR. Can you...
SVG ISR. SVG ISR.
Oh, SVG, saphenous vein graft. I have no experience. I mean, it's a long time we don't treat SVG, but I think in saphenous vein graft, I'm still a little bit conservative. I would place a stent.
And the third question, what's the pattern of restenosis after DCB? It's focal, diffuse.
Oh yeah, most of the time is focal. But that's the reason why I like because even if you have restenosis, because it's not 0%, you will have some restenosis, is usually focal, usually, yeah? We had some cases of total occlusion, but rare. Most of the time is focal.
Thank you, Antonio. Some good message, I think, for all of us. If you want to do ISR with the coating balloon, as you mentioned, I just wanted to stress the point. Use a scoring balloon or a cutting balloon before you do the coating balloon itself.
Absolutely.
I think that's an important message for everybody in the audience.
And the other important, you have to do a good pre-dilatation, because if you don't have a good result, and for ISR we use a lot of IBUS, make sure the pre-dilatation is well done, otherwise it's not going to work.
Dr. Mustafa, please. Dr. Mustafa.
Dr. Colombo, do you think there is a need for dual antiplatelet therapy in case of the severe angioplasty, and those patients with antifibrillation or anticoagulation?
But we always give dual antiplatelet therapy at least for 2 weeks. Because you have dissections, you have injuries, the lumen. So for 2 weeks, we give dual antiplatelet therapy. And of course, if we implant a stent, sometimes we implant a short stent, then we give at least 3 months.
I just want to ask you a practical question. With the new generation of DCBs, the drug is embedded in the balloon. So one of the rules of DCB not to touch the balloon.
Yeah.
Balloons 40. I think sometimes you touch it in a way because putting the wire in the balloon. What do you think about that, and what we can do?
But you don't have to touch the balloon. You have to, if you put the wire in the balloon, you have to keep the balloon at the end, not over the balloon. If you tremble, you ask your assistant, which is usually young and can do it well.
The younger assistant. We were asked by colleagues about using the coating balloon for bifurcating lift main. And I noticed that you had a case which you left with a black coating balloon for the lift main itself, right, Antonio?
Yeah, sometimes, but for left main, I tend to be conservative. At least left main LED, 90% of the time I place a stent. But if the result is really perfect, has to be perfect, maybe I use only drug-coated balloon. But I want to be a little bit safe. And if the vessel is 3.5 or 4, what's wrong to place a stent? And there's no reason to stay.
In terms of pressure gradient across the lesion, what do you use? Do you use the FFR wire or use a special equipment? What do you do?
No, I use the pressure wire, the regular pressure wire, and
Pressure.
I like to have I measure PDPA. I like to have PDPA at the end of the procedure more than 0.9. 0.9, especially I leave the wire 2 or 3 minutes, and I like to see that the PDPA tends to go better, to improve. Sometimes it's 0.9, and after a couple of minutes, it's 0.92, 93, 95. That's a very good sign. If at the end of the procedure is 0.9, and after 2 or 3 minutes is 85, 86, that's bad.
Well, interesting, because we don't, do you have pressure wire in Cairo? I mean,
Yeah,
just-
yeah.
You do. I'm not sure we have it in Jordan, the pressure. Do you have it in Palestine?
There is a question.
Okay, well, there's a question, Dr. Sam, please.
Thank you, Dr. We are honored to talk with you. Really, I saw that you did drug coating balloon for osteal major lesions, especially for circumference. We have some cases with tight osteal isolated, we consider as it means, isolated circumference. Doing prolonged inflation, say, lift made for about 40, 50, 1 minute, is it a problematic?
Yeah, I leave it 1 minute. Most of the patients, even for left main, they tolerate 1 minute. The minimum is 45 seconds. According to the instruction, is 45 seconds. But if he really doesn't tolerate, I deflate a little bit and re-inflate. But most of the time, 45 seconds is well tolerated.
Intermittent inflation doesn't work. With deflation every 10 seconds, why?
Maybe.
What-
Antonio, he said intermittent inflation of the balloon rather than continuous.
Now, you can do intermittent inflations, but you know, the point is that if you deflate the balloon and you leave the deflated balloon in the vessel, you lose the drug. So, but it's not frequent to need intermittent inflation. I tell you, 45 seconds, they tolerate.
Sure. Antonio, I like to learn from your ideas, which are visionary for the future. You know, I like the slide which you put for the one bifurcating lesions. The slide which you put in,
Yeah.
how you perform it. And the way I look at it, this is an Antonio Colombo modified DK crush technique. So you modify the DK crush in a way which makes it simpler, by the way. It's a lot simpler.
Yeah, but I use, you know, I was in love with the crush technique. I popularized this procedure, but nowadays I rarely used. Most of the time on the side branch, I go with the balloon, and if I need a stent on the side branch, I use a T-stent.
Brilliant. We have a question from the floor.
Thank you, Dr. Antonio, for this nice presentation. Actually, I have 2 questions. How you can explain the conclusion of the basket small 2 trials is that they say that the safety and efficacy of DCB versus drug-eluted by stent in small, even small vessel PCI is poorly defined, and we need more evidence. So you agree with this conclusion or not? It is the same of the basket smaller. They conclude that the safety and efficacy of DCB is poorly defined. This is in the conclusion.
Is not is reasonably well defined, because we have the basket small and we have DCBs that being used for many years now. So I don't think is undefined. Of course, the more time goes, the better it is. But I think the safety is well defined. So DCB are safe.
The second thing is that in bifurcation, especially the left brainstem bifurcation or large bifurcation, is it mandatory to use imaging?
Yeah, I think in left main bifurcation, I like to use the imaging in left main. And in left main bifurcation, I'm not convinced that we are ready to not implant a stent. In left main bifurcation, I prefer to implant a stent from left main to the LAD and do DCB on the circumflex. For me, this is a reasonable approach.
We have another question. Go ahead.
Just quick question. What's your take on DCB on stubby lesions? Any experience, any recommendations?
I do not have experience, but I know other colleagues that have experience. Dr. Sandeep Basavajan in Manchester, in Birmingham, UK, is doing a lot of DCB in acute coronary syndrome, including ST elevation MI. There is a big randomized study going on in Spain, more than 1,000 patients, and so far the results are good with no occlusion. So I think it makes a lot of sense to use DCB in acute MI, but I think we need to wait another year to see some results.
Another question on the floor, please.
Thank you so much. Thank you so much, Professor Colombo. While you are describing your way of doing the bifurcation and intervention, you mentioned that you prefer the DCB to be in the side branch when you finalize the result. Now, regarding the kissing balloon, do you think it is applicable to use DCB in the side branch and non-congruent balloon in the middle branch and do kissing with both, or go traditional with the two non-congruent balloon, finalize the kissing, and then you do the DCB for the side branch? This was not so clear to me, please. Thank you.
Well, when I do DCB on the bifurcation, after I prepare the lesion and I did kissing, I do DCB on the side branch and I inflate the DCB on the side branch for 40 seconds. I advance the DCB and I leave the DCB on the side branch, deflated. I take another DCB and I go with DCB in the main branch unless I implanted a stent. If I did not implant a stent, I do single inflation of DCB in the main branch, and then I deflate DCB in the main branch. I pull back the DCB that I left in the side branch, and I do a short kissing and then I remove. So the DCB are inflated individually to deliver the drug, and I just do a final kissing to remodel the bifurcation. But the individual inflation are needed to deliver the drug. I do not deliver the drug with a kissing inflation.
That's brilliant. Antonio, do you advise post dilatation and the DCB? Usually, I'm sure you will say no. But
no.
You don't do it.
No. DCB is the final. Of course, we have some cases where after DCB, we had a bad dissection or something happened and we had to implant a stent. It's rare, but there are some cases where after DCB, we got a deterioration and we had to implant a stent. Very rare, but can occur, can occur.
Is there a question?
No, you're saying we have only 2 minutes.
Oh, well, actually, we have 33 seconds, and I'll take the advantage of thanking you, Ahmed, for joining me, co-chairing this and our illustrious panelists here in the audience for sticking. Antonio, it's always a pleasure to hear your way of thinking about future coronary intervention. And hopefully next year you will be with us. Better.
Yeah.
Talk about it.
Next year, I promise. Next year.
Okay. Okay. Thank you very much.
Thank you.
Thank you. We have a session.